Few cataracts present at a stage which is too hard, and these patients may also have a pupil which is not very cooperative. These are my 5 super tips to manage these cases which are hard cataracts with small pupil which progressively becomes smaller during the surgery. Number 1 is that use direct chop technique which dissipates less energy and causes less collateral damage, and hence the meiosis is retarded. Second is used burst mode for initial chops so that you bury deep into the core of the nucleus to achieve good purchase and subsequently a complete chop. Make the nucleus into smaller chunks, so rather than having just 4 pieces, divided them into several pieces, more than 6 pieces. Avoid direct iris manipulation either by the instruments or letting them iris going into the wounds. And anticipate meiosis expansion device is ready. Also consider that there will be some hidden matter of the cortex or the nucleus which may be there behind the iris. And if these things are taken care of, one can manage these tricky situations using phacoemulsification. So this is one such patient in whom just in the OPD you can have an idea that this is going to be a tough case. Now this was a gentleman 75 years of age, pseudophakic in the other eye, and had waited quite long for this eye to be operated upon. And as you can see, the pupil is not very well dilating, and this is simply because of senile meiosis, and somehow these old patients, they don't dilate very well. Now the problem with these situations is that not only that this pupil is going to be not very well dilated, but with the progression in the surgery, this pupil is going to get meiotic. And any experienced surgeon will have a very clear idea about that how the surgery is going to proceed and end. So it may be a good idea to keep pupillary expansion devices ready for managing such situations if phacoemulsification is being attempted for these cases. Now here I will show you all the tricks which are to be used for such cases where you anticipate a progressive meiosis during cataract surgery and also with a hard cataract. Now first of all using a primary chop, trenching usually dissipates lot of energy which progressively increases the meiosis. So direct chop is to be a preferred technique. So here we will use a horizontal chop technique. Use a burst mode to bury the tip up to the core of the nucleus and beyond so that the chopping causes full thickness break in the nucleus, which is going to be very crucial for achieving the disassembly of the nucleus. And once a full thickness chop has been achieved, then subsequently one should be very judicious about how much to bury the tip. And these pupils are so meiotic that with the progression in the surgery, the iris may start prolapsing, and that will accelerate the meiosis because as much as the iris is being disturbed, the meiosis is going to increase. So one should take care that and the iris tissue doesn't prolapse into the primary wound or the secondary wound. And second thing is to keep the cornea clear the next day. Every attempt should be made to break the nucleus into very small chunks which do not protrude too much into the anterior chamber. The liberty can be taken to be emulsified in the pupillary plane rather than in the anterior chamber. And one has to be very careful that these pupils are so small that once you emulsify a piece, the iris tissue which is diagonally opposite at that moment in front of the tip gets exposed once the piece is being emulsified and consumed, and it is not uncommon for that iris tissue to be caught hold by the phaco tip. So one has to be very vigilant and very alert that the moment the piece is consumed, one should take care that it is not catching the iris. Here we can see some amount of iris traumatization has occurred at the side port, and at this moment the pupil is something like 3 millimeters in size, and one has to use some kind of retraction of the iris so as to clear cortical matter which is hiding behind the iris tissue. There is a small chunk of adherent cortical matter in the nasal half which will need more manipulation. One problem with these cataracts is the capsule is very fragile, so one cannot take a chance of reaching up to the capsule and sweeping these cortical fibers off from the posterior capsule. They have to be caught hold of either from the anterior capsulorhexis border, or else they have to be polished and lifted away using a blunt instrument or a capsule polisher so as to provide a lift from the posterior capsule. Then only it is better to handle these. So as viscoelastic has been instilled and that plate of cortical matter is being polished away towards the periphery so that it lies in the periphery away from the central visual axis. One strategy can be that once it has been lifted away, it can be simply aspirated safe distance from the posterior capsule, or else one can implant a IOL and take care that the optic falls behind this lifted cortex, and then safely the cortex can be aspirated out. Now implanting a hydrophobic monofocal single piece IOL, and we can also notice that by this time the superior one third of the cornea has started becoming hazy, and that is again because of these cornea, they don't have that much endothelial cell count, and repeated ingress and ultrasound energy causes these corneas to become edematous during the surgery, and that makes the situation complicated and difficult to handle, because then one has to work through this slightly opaque cornea, which causes some confusion in deciding what tissue or plane we are working at. IOL has been safely implanted, and then now we have a surprise we will see just now. In these situations, it is possible that small amount of nucleus material which has not been emulsified and has gone into the behind the iris tissue may be discovered at this moment, and here we have this chunk of nucleus which was hidden behind the iris tissue, and it has now prolapsed into the visual axis. So one has to pull out the phaco handpiece again and aspirate it and emulsify it in the anterior chamber, which has been done, and then one can proceed to close the case. And this is the day 1 post-op. We can appreciate some amount of corneal edema. The day 7 situation where the cornea has cleared out reasonably, although they are very minor Descemet's fold, which will subsequently clear at day 30 when the patient is being let off the observation and treatment part. So these cases can be managed without pupillary expansion devices, and they have an excellent outcome if these things are taken care of. Thank you.